Good morning. Happy Friday. Hope the sun is shining where you are. Here in Toronto, it's finally out after a week of rain. I'm Eleanor Colledge. I'm a family physician in Toronto. I'm delighted that you're joining us today for our next session of Changing the Way We Work, a community of practice for Ontario family physicians. I'm delighted that we can continue to offer you these sessions in collaboration with the OCFP, and I'm going to turn things over now to Jobin, our president, to introduce the session.
Thank you so much, Eleanor. And we're thrilled. Next slide. As we continue to provide these, it's so important for us to be able to bring really important and hot and important topics. And so we're thrilled to bring our speakers and we'll introduce in a moment. As we go to the next slide, it's a reminder that these sessions are accredited. And even if you miss a session, you're able to get credits as well afterwards. And so we do have a link that allows you to fill it with about 60 seconds. Next slide. With that, I'm going to go into land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. This land acknowledgement is even more special as September 30th does mark the National Day for Truth and Reconciliation, which honors the children who never returned home and the survivors of the Canada's 140 residential schools. Also responding to Truth and Reconciliation Commission's call for Action 80, which called for a statutory holiday so that public commemoration of this history remains a vital component of reconciliation. For family physicians, this day is more than just symbolism. Our CFPC Colledge recognizes that the National Day for Truth and Reconciliation is committed to addressing the harms that Indigenous people continue to face in the healthcare system. Now, reconciliation is not a one-day event. There are 94 calls to action, and only a fraction have been completed. And we all have a role to advocate for change. I invite you to wear orange on September 30th and support Indigenous-owned businesses. Seek out local events like the Indigenous Legacy Gathering in Toronto or powwows all across Ontario, which are vibrant cultural gatherings, and non-Indigenous attendees are welcome, and the etiquette will be explained by the Master of Ceremonies. Using resources like nativeland.ca, native-land.ca, to learn whose territory you live on, and read the Truth and Reconciliation calls to action. If this day brings difficult feelings for you or your patients, remember there are supports like the Indigenous Residential School Crisis Line, which we'll have a link, have a number to in the chat, as well as the Hope for Wellness helpline. Let's use September 30th as a catalyst to continue listening, learning, and acting towards equitable care for First Nations, Inuit, and Métis people. Back to you, Eleanor.
Thanks, Jobin, for that reflection and a reminder of that important upcoming day, as well as the work that still needs to be done. I'm calling in from Toronto, which are the lands traditionally used by the Wendat, the Anishinaabe, the Haudenosaunee, the Chippewa, and the Mississaugas of the Credit. I wanted to remind everybody that we have past sessions available online, as well as today's session will be posted with the resources in the Q&A after the fact. And also, of course, a big shout out to our planning committee who make sure that everything runs smoothly every time that we present. Next slide, please. I'd now like to introduce our two panelists for today and ask them to speak to their disclosure. So turning things over to Dr. Warshafsky first. Thanks.
Hi, morning, everybody. Daniel Warshafsky. I'm an Associate Chief Medical Officer of Health in Ontario, and nothing to disclose.
Excellent. Thanks very much. And Dr. Shah.
Good morning, everyone. I'm Hemant, your friendly neighborhood hepatologist. I'm at William Osler, and I have nothing to disclose other than some program support from the Ministry of Health for some educational activities I participate in. Thank you.
Thanks very much. Next slide, please. Jobin.
Yeah, thanks so much. Hi, everybody. As I've mentioned before, I have an honorarium through the Ontario College of Family Physicians to serve as president. I also have a role within the Toronto Metropolitan University School of Medicine as the interim assistant dean of primary care education, and William Osler Health System as the associate vice president of academics.
Thanks, Jobin. And I've already introduced myself, but I'm a family physician. I get an honorarium from the OCFP. I also actually do have the role as CPD program director within the U of T, within the Department of Family and Community Medicine, and do some work for the Foundation for Medical Practice Education, none of which poses a conflict for today. Next slide, please. So just a reminder on how to participate, and I see lots of hellos in the chats already, so that's lovely to see. Please use the chat for sharing your thoughts, your opinions, your resources, saying hello, and then please post your questions in the Q&A. And just a reminder, if you see a question that you would like answered, don't write it again, just upvote it so that I know as the moderator which questions are most popular and can ask those ones. Next slide, please. So without further ado, I will turn things over to Dan to get us started.
Great. Thanks so much, Eleanor. Hi, everybody. So just going to give a quick update today on what we're seeing and expecting for the respiratory season. So an overview first of what we saw in the Southern Hemisphere this year. We like to take a look at what they're doing. It isn't an exact correlation. We don't follow directly what we see in the Southern Hemisphere, but does give us kind of some direction that we might potentially expect. If we look at the Southern Hemisphere, then COVID activity was relatively low for this season. Their season was dominated by the NB181 strain. We've since moved past that already in Ontario. We're on to XFG, which is probably what's going to drive, which has been driving our current increase since the midsummer, and it's probably going to drive most of our season. But overall, their season was not too bad, and they saw a similar, continual decline in uptake of vaccine as we have in the past couple of years here as well. So it's a fair comparison. Flu was again elevated from kind of the baseline that we've seen pre-COVID, but a little bit better than the previous year had been. So similar to kind of the trends that we've been seeing in Ontario as well. It was an H1N1 dominant in most of the Southern Hemisphere, and there was also a fairly large B component as well, leading to a bit of that bimodal peak that we saw in that overall extended season. But what they did see was that the vaccine strains were well matched, which was a good thing to see, although again, coverage a little bit lower. Finally, for RSV, trends were following a little more typical or declining. It's getting much harder to tell what's an RSV season, given, of course, the introduction of the new RSV vaccines and monoclonal antibodies, whether that it's an impact from those products or just the season itself. Certainly, they still saw the same trends overall in terms of younger infants being those impacted by RSV, but it was a better season than the previous seasons. So again, not exactly what we're going to see here. Obviously, there are going to be differences from the Southern Hemisphere, but at least it gives us some reassuring direction that there wasn't a severe season for any of these with kind of overlapping peaks that would be really concerning for us as well. So next slide, please. Just to recap what we've seen in the last few years here in Ontario and in Canada, I like to show the difference between all of these. So you can see that the dark blue line is the very, very start of where we're at right now. So if we look to COVID, number one, it's not really fully seasonal yet. You can see the differences from 22, 23, 23, 24, 24, 25 in terms of when we start seeing the increase in cases and the amplitude of those, at least for this season. So you can see we are starting to see the increase now already. It's been since August already that we've been having increasing positivity for COVID, but we're still way lower than we have been in the last 3 seasons, which is really, really nice to see. So hopefully that trend continues. Flu, we've had varying starts this season over the last few years because the pandemic really altered those timelines, but it keeps getting closer and closer to kind of our standard flu. And last year was pretty on par with our normal flu seasonal timing, although again, still seeing more flu overall strain than we had in previous years. And again, RSV, we had that really bad 22-23 season with that early season, a big bump, but again, back to kind of normal timings. So we're seeing those typical seasons with the peaks where we normally expect them for flu and RSV, but COVID again still seems to be off, but it seems to be settling more into something that starts off earlier into the summer in terms of increase in peaks, probably and hopefully earlier in the fall, so it's not overlapping with those other ones. Next slide, please. This is where we're at right now. So this is from the PHO Ontario Respiratory Virus Tool, which is really nice to see. So everything is still low. which is great. So COVID has been going up slowly since mid-August, but we're still below 10% for everything. Flu and RSV are essentially not here, less than 1% positivity. COVID's starting to peak up to around 9%. In some parts of the country, we're seeing over 10% positivity, so kind of a start to season in a few provinces. But here we're still seeing it quite low. And again, XFG being the one that's really dominating our season so far. Next slide, please. So quick reminder of our programs for COVID and flu timing. Starting already. So COVID started probably this week in terms of distribution of products. Flu vaccines probably next week will start going out. And so that beginning phase now, so as soon as you receive the vaccines through beginning of October is, again, firstly going to hospitals, long-term care homes, and those really highest risk settings. And then as soon as more is available, coming to primary care providers and then to pharmacy as well for those priority populations, and expecting October 27th when we'll have supply to open to the general population. Next slide, please. The products that we have this year for flu and COVID, the big differences are for flu. We have a trivalent product now. We don't have to have the quadrivalent anymore. The B Yamagata strain is no longer with us, thankfully. So we have to worry about the three main strains. There's the standard dose product that comes in a multi-dose vial or a pre-filled syringe for everybody. And then the enhanced products, either the high dose or the adjuvanted, are all pre-filled syringes. NACI has made it very clear that either the adjuvanted or high dose can be used for the higher risk adults, and there isn't a preference between them per NACI. For COVID, we still don't have Novavax this year, unfortunately, due to manufacturing issues. So it'll be Pfizer and Moderna. Couple variations, multi-dose vial, pre-filled syringe, but again, either product is equivalent per NACI and either can be used. The only difference is for the younger children, Moderna is the only one available for the 6 months to 5 years range. So next slide, please. I just want to go a bit over what we saw in the last couple of years for essentially the coverage that we're seeing for flu uptake in, this is hospital staff and long-term care home staff. So someone we follow regularly, this goes back to, you can see 2007-8 season, where we have significant ups and downs in terms of actual coverage. Really what we've been seeing, and I think the issue is a pretty steady decline since peak in the pandemic. It looks like for long-term care home workers, at least, that has leveled off. So staff, it's always been higher in long-term care home staff given the risks in that setting. So it's about just under 62% coverage, and it seems to have stabilized in the last year. So hopefully that stays. Unfortunately, for hospital-based staff, we're seeing a continual decrease in uptake of flu vaccine. We're below 33%, and that trend still seems to be going down. So we'd really like to see these numbers go up. So everybody, tell your friends, if you're working in a hospital or long-term care home, just remind people of the importance of getting immunized. Next slide, please. So a reminder of what our new RSV program is for older adults. So we've had the high-risk program now since 2023-24 season. So that's realize it's very tiny writing now, but that's the group of high risk. It's predominantly long-term care home, retirement home, other similar congregate setting residents, some high-risk medical conditions, and then people experiencing homelessness and people identifying as Indigenous who are available for, so ages 60 plus for the high-risk program. And as of this season, we'll now have all adults 75 and older able to receive RSV vaccine as well. There's two products. There's the Arexvy and the Abrysvo. They are equivalent in terms of effectiveness, and NACI is recommending either one. In terms of how long they last, that's the important thing. We have really good data that they're lasting at least 3 to 4 years in terms of protection provided. So anybody who's received a vaccine from RSV in Ontario since our program started, they're still good. They don't need another one yet. We don't know exactly how long, if it's going to be a lifelong protection or not. Essentially what we're seeing right now is following all of these products as they're in use to see what protection is, but we're still seeing that really good protection out to 3 to 4 years, at least for those ones. In terms of the actual administration, this will only be available in primary care providers' offices, and again, those high-risk settings where they have been before, hospitals, long-term care homes, etc. RSV vaccine is not available through the publicly funded program in pharmacy. Pharmacies can only administer the private pay for the RSV vaccines. So strongly encouraging everybody to get this available for their patients as well. Next slide. Just a quick recap of where we're at with our RSV vaccine uptake. So again, this is just long-term care homes for the last couple of years. So that's what we're showing here. 23-24, we had just under 71% uptake. So not too bad, actually, for our first season of program. We had that bump up again last year to just under 77% coverage. So it's getting to be pretty good. It is still quite a bit lower than flu in long-term care homes. For flu coverage, we see it close, 90% is around the median for most homes. So we'd really like to see RSV get to that same level. And again, particularly in that multi-year protection, hopefully we'll keep seeing this increase. Next slide. And so lastly, quick reminder of the infant program. So we continue to have Beyfortus here. It's for all infants born during the RSV season. And any infant born, the change this year is born on or after April 1st. So after the end of the previous RSV season, they are eligible as long as they are less than 8 months of age at the time of administration. So if they're born April 1st, if my math is okay, they're eligible basically until November, after which they're 8 months old and they would no longer be eligible for Beyfortus. That's based on the NACI recommendations, and that we see the risk decrease a fair bit as infants age. And once they're over 8 months, the risk of hospitalization or severe outcomes from RSV is significantly lower. So Beyfortus is still there. No change in the high risk program. So that's for kids up to 2 years of age who are high risk with a number of medical conditions. That's still the same as it has been for many, many years in the Synergist program and remains the same now. And no change in recommendations for pregnancy. So we do still have a Brisvo available for pregnant individuals who would like to get that immunization for themselves rather than Beyfortus for their infant. NACI still has not changed the recommendations, and Beyfortus is still preferred, although we are starting to see some real-world evidence looking that maybe they're closer in effectiveness than we saw in the initial studies. So distribution of this product will have already started, so you should mostly be able to order it now, but we aren't starting administration until October 1st. And again, that timing is to make sure protection throughout the duration of the season. Next slide. And this one, just interesting. So this is Quebec data on their RSV program last year for Beyfortus. It's just wonderful to see, like, time and time again for Beyfortus, we're getting, and this is Canadian data just from last year. The effectiveness absolutely holds up, exactly what we saw in the randomized controlled trials initially. So you can see against emergency room hospitalizations, ICU admission, it's in the high 80s to low 90% effectiveness. So like 88% on average effectiveness against these outcomes. So again, really excellent product, Beyfortus. Next slide. So this is the overall timing for everything altogether. RSV older adult, you can already order. You've been able to order for a couple of weeks. Most of the health units should have been letting people know that ordering is available. With that distribution and administration can start at any time for the older adult products. Again, it lasts multiple seasons, so we're not worried about it running out. The infant RSV products would have just started going out this week, but we're not administering them until after October 1st to make sure that we have coverage for the whole season. COVID vaccines, again, probably would have just started going out this week as well, mostly to hospitals and long-term care, but if in your region they're getting through those highest risk centers, maybe coming to primary care as well now. And then next week, expect to start distribution of flu vaccines. And then general population administration for flu and COVID will be end of October. I think that was it. Oh, I had more. Right. Sorry. Quick update on antiviral medications of COVID. Couldn't remember. For COVID and flu. So in terms of antivirals, same ones are still available. Paxlovid and remdesivir are still available under the same programs and covered through ODB for individuals who are eligible. The Ontario Health Clinical Guidance is still where you look in terms of who's eligible and recommended to receive those treatments. For flu, Tamiflu and Relenza are the two products available for treating symptomatic patients who either in long-term care homes or tested positive for flu, or empirically in your offices, so we don't have flu testing available, as well as for prophylaxis in outbreak settings. Again, still reminding everybody to get the vaccines. It's not a replacement, but this is available. And again, strongly recommend you speaking to patients who are high risk and potentially eligible for these products before the season, so have a plan in place. I think I do have one more slide, actually, Eleanor. Sorry, one more. So access to testing and treatment, same as what we've seen in previous seasons. So it's still a test to treat policy in terms of respiratory viruses. So if you're eligible for treatment for COVID-19, you're eligible for PCR testing and rapid antigen testing. Rapid antigen tests remain available for primary care providers to order through the same Supply Ontario portal. I think someone's already put the links in the chat for that one. But again, testing is for the purposes of treatment. If you aren't going to be eligible for treatment, or if a patient's not eligible for treatment, there is no benefit in testing. Everybody should be staying home while they're sick until they're better for at least 24 hours after symptoms resolve, regardless of whether it's COVID, flu, RSV, metapneumovirus, whatever it is. They should just be staying home while they're sick, so maybe not passing on to anybody else. Doesn't matter if it's COVID specifically. I think that was the last slide now, Eleanor.
Excellent. Thanks very much, Dan, for bringing us up to speed, and also importantly, letting us know kind of about the dates of when the vaccines are coming our way. So a couple of questions. Actually, the first one around Paxlovid. Are pharmacists still able to prescribe Paxlovid and have it covered by OHIP if there's a positive COVID rat?
Yeah, they are. Again, the coverage is for patients who are on ODB or otherwise having public funding for it. If they could still be if they're still eligible for it, but on ODB, they can still get the testing done. They'll just be paying for the actual Paxlovid itself. But for ODB, it's fully funded, and yes, pharmacists can still prescribe.
Great. And then a couple of questions about the COVID vaccine for healthcare workers. So first of all, are healthcare workers now able to get the COVID vaccine? Aren't they considered high risk regardless of medical conditions? And can you please answer live and write your answer so I can show the pharmacist? Thanks.
Yes, healthcare workers are considered high priority. So one thing to just in the guidance or the fact sheets that you'll see, and again, the links are in the chat, we kind of differentiate between high risk for severe outcomes and high risk for transmission. Healthcare workers are high risk for transmission, not necessarily severe outcomes, of course, unless they otherwise meet those. But still, they are priority to receiving vaccine as soon as available this month up until like before the October 27th date. Again, in your region, it might still be doses going specifically to hospitals and long-term care homes first. But as soon as it's done in those highest risk settings, then the rest of the high risk groups, which includes healthcare workers, are able to receive it.
Great. Thanks for clarifying that. And actually a follow-up question, and I think you've really answered this, but at what timing do you recommend the COVID booster be given to a healthy healthcare worker in order to provide like the best coverage for the upcoming season?
Yeah, probably right now, as soon as you can get it, given that we're already seeing the increase. Again, just making sure you have the minimum interval of 3 months for healthy healthcare workers. You would have gotten it last year. So we're well past the 3 month interval. We do still need to maintain that 3 months for any higher risk individuals who got it in the spring season, because we don't see the same protection if we're getting too close. But otherwise, yeah, we're already seeing the increase, like I said, so we're probably going to see that soon in terms of significant season. So get it as soon as you can.
Right. Okay, great to hear that. The other question actually just around vaccines and how well they're working. A question, do the legacy vaccines that we all got in 2021, 2022 still offer any protection? Or because they were directed against spike proteins now not circulating, are they useless?
It's a really good question. And it's really hard for us to see in the studies and differentiate protection specifically from, the initial versions of the vaccines versus individuals who also had COVID since then, because probably everybody has also had COVID since then. What we can see is that, again, for most younger, healthy individuals, your protection is very good and the risk of severe outcomes is extremely low, probably whether or not you get the vaccine. That's why the NACI recommendations for, again, younger and healthier individuals are kind of a may get instead of a strong recommendation, because the primary reason to get these is to avoid ER visits, hospitalizations, visits to your doctor's office. And so if you're just going to get mild illness, again, the benefits aren't there in the same way. Absolutely, there is a difference when we look at older adults in particular, but anybody who's in those high risk conditions, number one, we do see that faster waning of immunity between doses or infections. So it's important to keep that protection up as much as possible. And we do see the benefits against hospitalization in those populations, given the risk of hospitalization so much higher.
Great. Thanks, Dan. Another question just regarding the vaccine. Where can kids under 2 get the COVID vaccine?
Really good question. Predominantly, that's still in mostly public health clinics is probably the main place available for kids under 2. There are some hospital sites who may still be doing it for really young children. And again, there are pharmacists, and pharmacy can do children 6 months and older for COVID vaccines. The issue is that because there's such low demand for really young children to be getting this, and again, NACI isn't recommending infants or young children to be high risk for COVID vaccines. Their priority for COVID to align with flu, because they certainly are high risk for flu. So because the demand has been so low, we don't see nearly as many sites available. So if you're not sure in your region, like the first thing I would do is contact local public health unit to see if they're aware of who might still be providing it.
Okay, great. And then last question regarding COVID. Are COVID cases lower now because people who wanted or needed their summer 6-month booster vaccine couldn't get it when the vaccines were pulled, and then they got COVID in the summer rather than now, and most cases are not captured with the lack of testing? I'm wondering what you think about that in terms of where we're
Okay.
at these.
But to parse that one out a little bit in terms of the question. So in terms of our surveillance, so what we follow predominantly is percent positivity of tests, not the absolute volume of testing. And that's been consistent over many years. So even if the volume of testing goes down, the percent positivity still remains a valid indicator of the level of COVID we're seeing in the community. Similarly, things like hospitalizations, we obviously track every hospitalization from COVID-19. So we can see that those numbers are lower than they were in previous seasons. Whether people not having gotten their spring vaccine means more got it during the summer, and so that's why it's lower now. I think that was the question. It's a great question. I would expect that getting the COVID vaccine in the spring is more likely to decrease cases now because you have protection for a good 3 to 6 months afterwards, as opposed to not having gotten the vaccine, then gotten COVID during the summer when it was like this was the lowest COVID we've had since like the beginning of COVID this past summer in terms of percent positivity and hospitalization. So transmission was really low. I don't expect that most people got it over like June and July in the summer, and that's why we're seeing it low now.
All right, great. Thanks for that. Switching topics, in terms of the RSV vaccine, how to decide between a Rexv and a Brisvo for adults that are non-pregnant?
It doesn't matter. They are equivalent per NACI. The effectiveness we see is the same. The only difference is because Arexvy has been available for one more year, we have one more year of real-world data on how long it lasts. But in terms of the trends, we're seeing that effectiveness is essentially the same over those years for both products. So I wouldn't have a preference between either of them.
Okay, and I think there was another question further down about I believe you might have answered this last session, but if someone had the RSV vaccine last year and now turned 75 this year, would they require it again?
No, again, we're seeing multi-year protection at least 3 to 4 years for a Rexv and a Brisvo. So if they got it last year, they're still good for at least a couple more years. We don't know, again, we don't know exactly how long it's going to be. Is it going to be 5 years? Is it going to be 10 years? We're still waiting to find out, but certainly don't need another dose yet.
And thank you for that. And then a reminder, if we want to acquire RSV for the 75 plus population, do we order it through public health or do we send a prescription to the pharmacy?
If you send a prescription to the pharmacy, they'll have to pay for it. So don't do that if they're going to be covered. Yeah, it's ordering through public health, the same as for any of the other immunizations that you order.
Excellent. And a question regarding the flu vaccine. Choosing between the two flu vaccines for seniors, is there a choice to be made? Advantages, disadvantages of either?
Yeah, again, really good question. NACI for the last couple of seasons has said that it's equivalent between all of the different enhanced products. So there's the high dose, the adjuvanted, and there's also a recombinant product that we don't have. The studies that we have all compare those enhanced products to standard dose, and they all show significant benefit compared to standard dose. We don't, unfortunately, have like head-to-head studies directly comparing the different enhanced products. So we don't really know if there is a better one between any of the enhanced. So I'd love to say I knew which one it was, and because I just know, but unfortunately we just don't have the data to say which one is better. At this point, whichever enhanced product is soonest available to them is probably the best one to be giving.
Great, thanks for clarifying that. Another question which I believe you answered is when will OHIP covered Beyfortus for infants that were born in the summer be available? If you remind us of that.
So again, that you should be able to order supply starting now from your local public health unit. The supply is available. Administration starts October 1st. So we want to make sure the coverage lasts the duration of the entire RSV season. So that's why we're waiting for that data to start administering.
Okay, and I'm going to finish off with a couple questions before we turn over to Dr. Shah. So first is, what's the current thinking about the timing of the COVID vaccine after you've had a COVID infection?
Yeah, a really good question. So, following NASA, they've had recommendations for a couple of years now on it. It's probably the same timing as since your last vaccine, with at least 3 months afterwards. For younger, healthy adults, do we see that it probably lasts a little bit longer than in terms of protection? Probably. But in terms of the benefit of the vaccine, you still get the same effectiveness from the product after at least the 3 months have passed. So I think 3 months is a pretty reasonable interval to be using.
Great, thanks very much. There are still some questions in the Q&A. Maybe you can have a peek at them while we hear from Dr. Shah, and then we can come back to you after if we have time. So I'm going to turn things over now to Dr. Shah.
All right, great. Thanks, everyone. Learned a lot during that last session. And while you may think that infectious disease and what we're going to talk about now are seemingly unrelated, I guess I'll just point out that we'll be talking today about two important population health issues in Ontario. So maybe that's the connection. So I will talk a bit about metabolic associated steatotic liver disease. It's a bit of a mouthful, and many of you will know this as non-alcoholic fatty liver disease or NAFLD or just fatty liver disease. The nomenclature of this condition is changing. So I'll just review that as well today. But we are just talking about fatty liver if you're not familiar with this term. Next slide, please. So three simple objectives for the next 15 minutes or so. One is to hopefully understand how to use the nomenclature for MASLD, as we like to say now in the liver world. Two, to improve your ability to risk stratify your patients with MASLD in primary care and activate your abilities to prescribe some management of MASLD. Next slide, please. So this is the updated nomenclature. The nomenclature was updated a couple of years ago in a consensus statement, really to de-emphasize that this is a condition that is like alcohol-associated liver disease, but without the alcohol, and emphasize the fact that the underlying pathophysiology is metabolic dysfunction. So the umbrella term is now steatotic liver disease. But within steatotic liver disease, there is a spectrum of illnesses depending on their specific etiology. The common thing amongst all of these is that on a liver biopsy, they pretty much look the same. Maybe some nuances in terms of different features. We're going to be talking about what's on the left side of this slide, metabolic dysfunction associated steatotic liver disease, or MASLD. Many of you in practice probably see patients with MET-ALD, which is those patients who have clearly metabolic dysfunction. They have diabetes, they have high blood pressure, but they also consume excessive amounts of alcohol. And they have fatty liver disease. So the etiology of their fatty liver disease is not one or the other, it's a combination of the two. So that's MET-ALD. Next slide. But like I said, today we're going to focus on MASLD specifically, so that on the left side, and maybe we can leave alcohol for a future session. MASLD itself is a spectrum. So if you can imagine a person who has a normal liver here on the left, they develop that first hit in the progression of this condition. So that could be, insulin resistance, typically, the genetic predisposition, whatever it is, and they go on to develop what we call simple steatosis or metabolic associated steatosis. If you look at people with normal weight, that's about 10 to 15% of the population will have some degree of steatosis within, and what these are really are triglyceride deposits within the hepatocytes. And if you look at an obese population, about 70 to 80% of people will have some degree of steatosis. Steatosis itself in the liver is not harmful. It's not a progressive condition that's going to harm the liver. It, of course, is a signal of the broader metabolic dysfunction that's happening. Some of those individuals will go on to have a second hit and further progress to develop what's called steatohepatitis. We used to call this NASH. Now we call it MASH. If you're as old as me, you remember that TV show. MASH is when you have fat in the liver and you have inflammation associated with it. And that's the precondition required for injury to the liver itself. So this happens in about 2 to 3% of individuals with normal weight. So it's not exclusively in overweight individuals, but more common in individuals who have severe obesity. About 20% of individuals will have MASH. And obviously, if this progresses over years and decades, those individuals can develop cirrhosis. About 3 to 5% of severely obese individuals will have cirrhosis at the time of, for example, going for bariatric surgery. Next slide. So what are the clinical features of MASLD? This is a bit of a summary slide of just the highlights. So in terms of symptoms, most patients will be asymptomatic. They will have no idea that they have fat in their hepatocytes. Uncommonly, some patients may experience some right upper quadrant discomfort. This comes from the hepatomegaly, or the stretch that happens to the liver. The liver itself does not have pain receptors within it, but there's a thin lining, a capsule of the liver, and that has some stretch receptors. So patients can feel like a dull right upper quadrant ache. Typically they describe it like 1 to 2 out of 10 discomfort. It's there most commonly throughout the day. Doesn't cause them any distress, but they acknowledge it, and you should acknowledge it too. It is a symptom of MASLD. Rarely patients will have fatigue and malaise, but I mean that's really hard to tease out from all the other stuff that's going on. Some of the signs: hepatomegaly. So about 75% of these individuals, especially on imaging, will have some degree of hepatomegaly. And of course, if they've progressed to cirrhosis, they may have splenomegaly and some stigmata of cirrhosis that we all learned in med school. In terms of labs and imaging, ALT is usually higher than the AST unless patients have cirrhosis. Patients who have cirrhosis from any cause, you can see a reversal of that pattern where the AST is higher than the ALT. So it's not just alcohol liver disease that causes AST to be higher than ALT. It can occur whenever there's cirrhosis present. So, if you see that pattern in your practice on a patient, just get your, spider senses tingling a bit that maybe this is not alcohol. Maybe this could be cirrhosis from some other unknown reason. About 20% of patients will have a GGT or an ALP elevation. So it's not common, but it's not absent, and can be this sort of what we traditionally consider biliary enzymes can be elevated in fatty liver. Very importantly, at a population level, fatty liver is the most common cause of elevated ferritin, and an elevated ferritin is not synonymous with iron overload. The correct test to screen for iron overload is a transferrin saturation that's done in a fasting state. If you see an elevated ferritin in a patient, start thinking about fatty liver before you think about they have too much iron. And of course, on imaging, you may see an echogenic liver, which is the fat deposition, which appears bright. Next slide. So what about screening your patients? I think this is like the big question in primary care. There's a recent consensus statement from a group of people who I think know a fair bit about fatty liver that suggests you should screen patients or think about fatty liver if any of the following are present. So first of all, if they have diabetes, type 2 diabetes. In that population, 80% of patients will have some fatty liver. Secondly, if they have obesity with a BMI over 30 and one of these other conditions, so impaired glucose tolerance, there's various definitions of that, hypertension, abnormal lipids. So if they have obesity and one of those other conditions, it's reasonable to screen your patient for fatty liver. And thirdly, of course, if they have an elevation of their AST and ALT for over 6 months without another explanation. I think in all of those patients, you should be doing some serologic testing to evaluate for potential causes of liver disease, and fatty liver being one of them. Then the question is, how do you screen them? So like you have this, you're probably thinking right now, geez, like this is like 50% of my patient roster. So how do you screen them? This is where there's unfortunately no consensus. And I think you have two basic options. So the first is you take this group of patients and you perform an ultrasound of the liver looking for fat. And if they have fat in the liver, then you move on to risk stratifying those individuals for, fibrosis and other bad things that can happen when you have fatty liver. Or you take the approach of, well, ultrasound is actually not highly sensitive for fatty liver. About 30% of patients with fatty liver on biopsy will not have ultrasound markings of fatty liver. So I should just risk stratify everyone. There is no consensus globally. If you look up this paper that I've referenced here, they will recommend option 2 to risk stratify everyone. But I think that, that's not always the Canadian way of doing things. We like to be a bit more thoughtful. So I think option 1 is also on the table. But like I said, there's no consensus here. We need a bit more evidence. Next slide. Importantly, MASLD at the end of the day is a diagnosis of exclusion. So when you have a patient where you're considering fatty liver, especially when they have mildly elevated liver enzymes, which is not all patients with MASLD, but many, always make sure you're going to exclude these 2 diagnoses: viral hepatitis, and there are 4 important tests to do. I've listed them here. Exclude hemochromatosis, so iron overload, especially in Caucasians. Hemochromatosis is the most commonly inherited genetic condition amongst people with Northern European ancestry. And exclude if it's relevant. So not in everyone, but in selective cases, you're obviously going to know a bit about their drug history, but drugs can cause fatty liver, certain drugs like, prednisone is an example. But these rarer conditions like autoimmune hepatitis, Wilson's disease, you don't need to do that full panel in every single patient when the pretest probability is low. That full panel is quite expensive for our healthcare system. So, in the spirit of choosing wisely, I think those are tests that are best reserved for select cases where, just something is not fitting the typical pattern of MASLD. Next slide. So MASLD and mortality, and this is really why bother risk stratifying. So the reason to risk stratify from a liver perspective, like to understand, does this patient have no liver damage from the years of, fatty liver they might have had before I made this diagnosis, versus does this patient have liver damage? Does this patient have cirrhosis? The reason to do that is that, first of all, the more fibrosis a patient has, the higher the overall risk of death from all cause. So they have a higher all-cause mortality. So that's an important reason to know how much fibrosis they have. You can help prognosticate that patient. Nonetheless, the most common cause of death in patients who have fatty liver is cardiac. So this is at its core a metabolic disease. So, a reminder not to forget that. The other reason that it's important to risk stratify is that patients with MASH, that steatohepatitis, when there's inflammation associated with the fat in the liver, those patients have increased liver-related mortality as well as increased overall all-cause mortality. So when you look at that, the general population, cardiac death and cancer death are like, number 1 and 2 typically. And liver-related death is usually about number 10 on the list of kind of your risk of what you're going to die of. But for patients with MASH, that goes up to number 3. So obviously there's an opportunity to intervene from a liver-specific point of view in those patients. As you'll see when I talk about treatment, all patients really should have a focus on treatment of their metabolic disease. Next slide. So how do we risk stratify? The best evidence, so first of all, I would say, when you're risk stratifying at a level where you have like 30 to 50% of your patients who are at risk, it really is important to have tools that risk stratify patients that are 1, non-invasive, 2, not expensive, and 3, have been tested at a population level. So the best test actually that's been tested at a population level, including in a Canadian population, would be the FIB-4 test. So the FIB-4 is a score. It's AST, platelets, ALT, and age. And I know there's a bunch of questions coming in about AST. I'm happy to address that in the Q&A. But you put these into a calculator and it spits out a score. And the value of this test is really, it's helpful in ruling out patients who have advanced fibrosis and cirrhosis. So understanding out of this group of patients who might have some liver disease, which requires not just metabolic management, but liver management, versus who doesn't, and in terms of a pathway, who can stay within primary care. There is a disease, the FIB-4 score is not a disease-specific score. It can be used for other conditions. There is a disease-specific score called the NAFLD fibrosis score. Probably the name needs to be updated. You can see it has not just lab values as within the test score, but also some clinical parameters. The challenge here is you might not have albumin on your patient. You might not have an updated blood, fasting blood glucose and that kind of thing. So it's a little less accessible, but again, can also be used in a pathway. And I'll show you that in a moment. Next slide. So there have been questions about FibroScan already. Anytime there's a new technology or a fancier technology, we would like to believe that all of our patients need it. Most of your patients with fatty liver do not need a FibroScan. Actually, I would say the vast majority of them do not need a FibroScan. This test is a non-invasive test that can be used to assess for fibrosis. It's an ultrasound-based technology, has a great story behind it about how it started in France and was invented really by cheesemakers to determine if their cheese was ready for, I guess, harvesting or whatever they call it. But it's an ultrasound test where you basically shoot a beam of sound through the liver, and the speed at which that sound travels has to do with the density. This is not publicly funded in any way. It is costly, and like I said, it's not always needed. It's slightly more accurate than the blood tests I showed you previously for determining the various stages of fibrosis, 1, 2, 3, 4, from distinguishing them from each other. In terms of how useful it is for figuring out if someone has advanced fibrosis versus not, it's probably just as useful for that purpose, for that blunt purpose. This test has not been evaluated in a population health screening program, the same way a FIB-4 has. So actually the amount of evidence we have for using this as a general screening test is less. Next slide. So what might a care pathway for MASLD look like? This is kind of one I created based on a few that are out there and some Canadian evidence specifically. So start in the top left. You identify fatty liver, whether that's through risk factors or imaging or some other way. You send the patient for an ultrasound because their belly hurts and their liver's got fat in it. Your job is to rule out advanced fibrosis. Does this person have a lot of liver damage? You already are going to be treating that person for their underlying metabolic disease. That's a sort of an assumption. So how do you do that? You can use a FIB-4 or a NAFLD fibrosis score. I've provided some cutoffs there. If your FIB-4, for example, is less than 1.3 or less than 2, if the person is over 60, then that is a low-risk individual who is unlikely to have any fibrosis in their liver, and you can monitor them every 1 to 3 years by repeating that FIB-4. Now, what if their FIB-4 is higher or their NAFLD fibrosis score is higher? Those individuals are going to be either intermediate or indeterminate or high risk. That's less than 15% of patients. So most patients are going to enter a low-risk monitoring pathway. About 1 in 8 will need further investigation. And these are the patients where you might refer them, or if you have access to further testing, you can do this in primary care. You're going to try to figure out and rule in or rule out advanced fibrosis. And that can be done with a FibroScan or some other technology. And then you're going to figure out, based on that, are they low risk, high risk, and they're going to move through a referral pathway based on that. Next slide. So what about treatment of MASLD and MASH? I'm going to be fairly brief here. Just focus really on what's proven. And the top 3, I think, are most relevant. Lifestyle, diet, and exercise with a target weight loss of 7 to 10%. Really good therapy, as I'll show you. Weight loss surgery, if BMI is greater than 35, really good therapy. In terms of medical management, the best evidence now is for semaglutide or GLP-1 receptor agonist. There's a phase 3 clinical trial that showed very good response for patients. And I'm talking about using it specifically for fatty liver, not for its weight loss properties, although obviously the weight loss property is probably what's driving the fatty liver benefit. There is another proven therapy, a drug that's not available in Canada, so I won't focus on it. You may have heard about all kinds of other treatments. They may be useful in some specific scenarios. I'm not going to review them all today, but I think if your armamentarium contains lifestyle, diet, exercise, referral to bariatric surgery for patients with BMI greater than 35, and use of semaglutide wherever possible, you're doing a fantastic job for your patients. Next slide. So what is the value of a lifestyle intervention? There was a question earlier about fibrosis regression. So patients' livers can improve if you manage the underlying cause of injury really well. And for patients who are able to achieve a 10% weight loss, if they have MASH or NASH, this study was done in the era where it was called NASH, if they are able to achieve 90% weight loss, 90% of the time their steatohepatitis will resolve, and 80% of the time their liver will start improving. The problem is only 10% of patients in this study of managed lifestyle intervention were able to achieve a weight loss of 10%. It's very difficult to do without medical therapy. But even you can see there's benefits at lower degrees of weight loss. So overall, this is still the primary intervention for these patients and obviously has proven all-cause mortality benefit, cardiac specifically. Next slide. A frequent question is which diet is effective? And this is, some data and reference for your benefit, but I would summarize the slide in two statements. So the first statement is when a patient doesn't have significant liver disease, any diet that sustainably can result in weight loss is going to be a benefit to the patient. When a patient has more advanced liver disease, we do need to be a bit more selective about weight loss and diet for weight loss. And in that circumstance, the best diet has typically been the Mediterranean diet. There's a lot of sort of epidemiologic evidence for this, as well as some specific trials. And you can review what the Mediterranean diet includes, but it's not like a keto diet. It's different, and it can be very effective for patients as a recommendation for patients with more advanced disease, and it's culturally adaptable. Next slide. I just wanted to show you this data for semaglutide. This is the Essence trial. This was published just this year in the New England Journal of Medicine. So this was a study looking at semaglutide specifically for the treatment of metabolic-associated steatohepatitis. And you can see that for resolution of steatohepatitis, 2/3 of patients after a year of therapy had a resolution of steatohepatitis. These numbers are much higher than we've seen with other clinical trials of potential therapeutics in this area, but not as high as diet and exercise. So, still, if that's the way the patients can achieve weight loss, it's preferable. But nonetheless, semaglutide is a good option. It's not on label yet in Canada for it to be used for this, but I would expect at some point in the future it will be. And obviously, there's associated other benefits for semaglutide in specific populations. Next slide. So just to wrap it up, a summary approach in primary care: screen the right patients, non-invasive assessment is your best friend, metabolic disease management for all, and semaglutide is your best therapeutic option if you're treating liver disease specifically or in the context of metabolic disease. Next slide. I just want to put in a brief plug for another program I'm involved in, and I know that some of you will be familiar with, is Project ECHO. This is a provincial program in Ontario funded by the ministry, CPD accredited. We have an ECHO liver that's co-facilitated by myself and a couple of other hepatologists. We have a multidisciplinary team where it's really very focused on primary care, where we do a slightly deeper dive into things like fatty liver, hepatitis B, hepatitis C, cirrhosis management, et cetera. And you can scan the code there and it will take you to the website for registration, which is free. Thank you.
Excellent. Thanks so much, Dr. Shah, for bringing us up to speed on the new nomenclature and also giving us an approach in our office. A bunch of questions have come in, so I'm gonna throw them at
Only
you.
50?
Well, Yeah, only 56. Actually, the first one, and this might require an entire other talk, but how do you work up mild high ALP? So not specifically regarding fatty liver, but something that I guess we often see in our offices as family physicians.
Yeah, I mean, it is like an entirely separate topic, how to work up elevated alkaline phosphatase. So first step is to really understand, is that ALP elevation coming from the liver? Like, it's not always from the liver. So if the ALP and GGT are elevated together, it's more likely to be from the liver. But if it's an isolated ALP elevation, just think about whether it could be from bone or something else. And then how do you work it up? You're going to treat it like a transaminitis, but you're going to really think a little bit more about primary biliary diseases, obstruction. So imaging is more important in the evaluation of alkaline phosphatase than it is for just isolated ALT elevation. There's some autoimmune diseases that we didn't talk about today, which can cause ALP elevation that are important to rule out. So it's a bit different. I'm happy to come back and talk about sort of elevated liver enzymes. We do talk about that topic in Echo Liver. So whoever asked that question, that may be a good forum to get that answered.
Excellent. Thanks very much. Just regarding some of the elevations that you talked about, like the ALT, the GGT, and the ALP, I just wondered if you could give us a sense, like when you said about 20% of people have like an elevated GGT, ALP, are we looking at really high numbers, low numbers? Like, is there any kind
Like
of
mild
range?
elevation? Yeah, I think yeah, maybe I should have been more specific, but mild elevation. So like, 1 to 2 times normal elevation. AST elevations can be a bit more. Like in fatty liver, you can see elevations like occasionally of 4 to 5 times normal. But on the biliary enzymes, you shouldn't really be seeing more than 1 to 2 times normal before you start thinking about other causes.
Okay, great. And there was a couple of questions around the ferritin. So first of all, could you just reiterate how you would test for hemochromatosis in terms of screening?
Yeah, so the best screening test for hemochromatosis is a fasting transferrin saturation, synonymously fasting iron saturation in some labs. That's what it's called. But that is the screening test for iron overload. So, for depending on the age and the sex, biological sex of the individual, there's different cutoff values, but you can roughly use a cutoff value of around 50% for all comers. And if it's less than that, you're probably not looking at iron overload, but if it is, you have to start thinking about it.
Great, thanks for that. And then another question regarding ferritin. How do we manage our Asian patients whose ferritin counts can be up to 1.5, 2 times higher in the absence of liver disease? There doesn't seem too much guidance around this.
I mean, I'm not a ferritin expert, I will admit. I think, ferritin is so non-specific. It's a marker of inflammation from anything. Like it's not the liver generating the ferritin somehow. It's actually that the metabolic dysfunction is inflammatory, and it's systemic inflammation actually. So that's what's driving the elevated ferritin here. Specifically, this question about, Asian population, I don't have an answer.
Okay, no worries. Thanks for speaking to that. So another question regarding testing, and I think you alluded to this, is one we face all the time is why do patients have to pay for AST when they're ordering? And I don't know how you deal with that. Yeah, some thoughts on that.
Yeah. So I mean, I very briefly. So this is something that I've been working with the ministry on for like 6 years. So someone made the decision in like 2011 or 2012 based on a cost analysis that there was overuse of AST testing. It was costing the province actually like 12 or $15 million a year. Most of them were probably not required. It was just every time someone ordered an ALT, they ticked AST as well. And so the government, like a decision was made after a health technology assessment to like basically remove access. So a further analysis has been done, and thanks to some advocacy from a few people like myself and colleagues, it looks like the government's going to bring it back, but not widely, and it's going to come back with criteria that basically allow you to use it when you are using it to risk stratify someone with known liver disease. So right now, unfortunately, it is restricted access to hepatology. Like if I write the labs won't charge, but if a family doctor writes it, the labs will charge. And we've made the argument to the government that you should allow everyone to write it, because if you can prevent referrals, it's actually a lot cheaper to do that than to pay for the AST. So it is coming back. Like I said, I've been working on this for 6 years. There's an overall revision happening to the lab, that lab sheet, like the ordering sheet in Ontario. So I think that it's kind of wrapped up a bit in that, but it will be coming back. What you can do for now is you can write recommended by hepatology, and the lab and the, behind closed doors, the government's acknowledged that this is an acceptable workaround in primary care.
Great. Well, I mean, thanks for advocating for us.
That's why my hair is gray.
Pardon? That's why your hair is gray.
That's why my hair is gray, is this specific issue.
And Ali's just mentioning in the chat that he just puts in brackets insured, and they're usually then covered. I sometimes just put like fatty liver in brackets, and I find that it's typically covered in those circumstances. But thanks for advocating to have it covered for us as family physicians. Moving on to some questions just around the ultrasound. So when fatty liver is reported on ultrasound, sometimes the report includes a grade like mild, moderate, or severe. Sometimes it doesn't. And I guess the question is, does the grade of steatosis on the ultrasound change how we should manage them, or is the management more about assessing fibrosis?
It's a completely subjective assessment by the radiologist. And the only thing that matters is whether it's there or not clinically. So, I know sometimes it's alarming with, for patients, they see this like severe echogenicity in their liver, and they're like, last year it was moderate. Like, what is, is everything getting worse? And it is clinically, unfortunately, it clinically doesn't mean anything and doesn't change anything in terms of the management. So I think just look for whether it's present or absent. Don't worry so much about the grade.
Great. Actually, that's really helpful for us when we're speaking with our patients. Similarly, another ultrasound question. So can you comment on whether there is any significance with the concomitant splenomegaly commonly reported in ultrasound in patients with fatty liver? Does this have any prognostic significance? And I would say also pancreas sometimes shows up there too. So just wondering about that.
So splenomegaly, I think the most important thing to consider in that scenario is whether it's from portal hypertension, which would imply that the patient has cirrhosis. And so, like, not all splenomegaly is from portal hypertension. The spleen can also have fat infiltration and get a little bit a little bigger based on that. But I think in the context of a patient with fatty liver, really think about whether they might have cirrhosis. So that means, looking at the non-invasive testing. We didn't talk about things like, looking at platelet counts and that kind of thing. But if their platelet count is a little bit low and their spleen is a little bit large, that patient probably has early cirrhosis from their fatty liver. And, that should prompt you to kind of move them forward in terms of a referral pathway. So I would say splenomegaly is typically absent from these patients. But when you see it, like, the most important thing to make sure they don't have is cirrhosis.
Great. Thanks very much for clarifying that. I'm just looking at the time. We're going to just quickly bring up the slides. We've got a couple to finish, and then we'll come back because I know there's quite a few more questions to ask you. Turn things over, I think, to Jobin.
Thanks so much. Yeah, I just wanted to quickly highlight a couple of offerings that we have for the Ontario College of Family Physicians, specifically our second Health Equity Community of Practice. This was going to be on equity-oriented primary care attachment on October 9th. We're looking forward to having this COP continue. Our first one was really successful, and we look forward to continuing to having further COPs as we continue to think about this as we go forward. The next slide is about our osteoporosis and fracture workshop. This continues to be a very highly sought after workshop because it's very practical. And so just pointing out, the next one will be on October 21st. And that is a 3 credit per hour main pro credit. Last thing to talk about on my end is just the communities of practice that we have, including our Practicing Well and our mental health, as well as our Peer Connect mentorship. So just pointing these out for everybody. And with that, I'll hand it back to Eleanor and Dr. Shah. Eleanor. And
Thanks, Jobin. Next slide. So just a reminder about some of our recent sessions. If you missed them over the summer or in September, then please feel free to check them out. Next slide, please. And a reminder, our next session is October 17th. And actually we'll be talking about nutrition then, which will be very applicable in terms of managing metabolic disorders. So it will tie in nicely with today's talk. Hope to see you guys then. If you have to sign off now, have a wonderful weekend. And for those of you that are able to stay on, we'll turn back to some questions. All right, back in the hot seat there. So some questions around treatment. You spoke a little bit about GLP-1 agonists, and there's a specific question here. Should we consider GLP-1 agonists if a patient has a BMI of 27 and MASLD?
Yeah, so great question. I just want to clarify. So the study that I showed you looking at the use of semaglutide in steatotic liver disease specifically was in patients with MASH, with steatohepatitis. So generally, the broad group of patients with MASLD, unless they have steatohepatitis and are at risk of liver disease progression or already have some fibrosis, we're not going to specifically treat their liver disease. We want to treat their overall metabolic disease. So that's kind of the context for the answer about treatment. When I was talking about treatment, I was talking about treating the liver disease specifically. And in that study, like there wasn't like a BMI cutoff for entry. Now, reality is most patients had an elevated BMI. But if you have a patient with steatohepatitis who has some fibrosis, might be progressing, and they can access semaglutide, it is a very reasonable therapy to prescribe. It is an evidence-based therapy to prescribe that patient, even if they're not overweight. So there is this group of patients, you sometimes see them, they're very perplexing actually, like thin MASLD patients, right? Or lean MASLD as it's referred to. So there are patients with normal BMI and they have metabolic dysfunction and fatty liver. The management of those patients is actually still aggressive, lifestyle intervention and weight loss. So even in those leaner patients, the use of semaglutide probably makes sense. Now, you don't want them to lose a ton of weight on semaglutide. So probably your dose, I think we're still figuring out a lot about semaglutide. I think we probably are using too high doses in some patients, and we're not doing enough dose titration up and then down and finding that stable level. But across the spectrum of patients with steatohepatitis, if it's accessible, then I think it should be started.
Great, thanks for clarifying that. And I think there's still a little bit confusion around like how do you differentiate steatosis from steatohepatitis? Because I think that also, as from what I'm understanding, then changes how you would be approaching it, metabolic versus liver specific.
Yeah, so unfortunately, there's no really straightforward, simple way to do this. There's no single test. So patients with steatosis might have elevated liver enzymes. Patients with steatohepatitis might have normal liver enzymes. So you can't use your ALT to differentiate. You can't use your ferritin to differentiate. Now, patients with steatohepatitis, they're more likely to have an elevated ALT, probably more likely to have an elevated ferritin, but it's not a hard and fast rule. So think about the outcome that we're trying to prevent in management here. We're trying to prevent liver damage. So, and the liver damage happens slowly, right? Like you don't have to try and prevent it before it's even happened. You can observe it, a patient. If there's liver damage, that's the time to start therapy in our current paradigm. So the way actually to practically differentiate the two is to look for fibrosis. Because if a patient has fibrosis, then they must have steatohepatitis. Simple steatosis doesn't cause fibrosis. So if you identify patients with fibrosis, and that's why the risk stratification is using non-invasive tools for fibrosis. If you identify patients with fibrosis, those are the patients in clinical practice to embark on therapy adventure with. And so how do you, if you wanted to differentiate like at the liver level, the way to do that is with a biopsy, but we're not biopsying all of these patients. I think, for what we need to do in practice, it's to look for fibrosis.
Great, thanks for clarifying that. And in terms of looking for the fibrosis, a couple of questions around that. Is the FIB4 test covered under OHIP, which I believe it would be because it's a series of blood tests?
It would be, it's the AST component, again,
Right.
of that test where there's sometimes inconsistent coverage. But hopefully based on like what you do, what Ali does, and what I've suggested between one of those three strategies, it will be covered by your local lab.
Another question just regarding the FIB4. Somebody asked, is there a lower age limit in terms of using the score? You had mentioned if they're over 60, it's slightly different.
Great question. And sometimes as an adult physician, I forget to mention this. But generally, those scores are validated for over 18. FibroScan is probably your best test for pediatric population. The challenge is in the pediatric population, you have to use the probe size is much smaller. And if you send them to like your local FibroScan provider, who's set up in a mall or something like that, they will not usually have pediatric probe available. So, because it's like a $30,000 probe that they almost never use. So I think it is a bit challenging. I generally think that, when you identify kids, especially if they're like prepubescent, it's important to get pediatric like hepatology involved, because there's all kinds of other things that could even be that, you don't want to sit on that in practice.
Great, thanks for clarifying that.
But a 16-year-old, you can probably treat like a kid. Just because I say they've not been studied in less than 18, I think if they're post-pubescent, the scores probably work.
Okay. Actually, another question regarding the FIB4 testing. What about the FIB4 testing that can be done at Life Labs for a fee of $20? I'm not familiar with this. I'm not sure if you are.
I'm not familiar with it, but I was looking at some of the questions. It sounds like Life Lab is just selling like I don't know, this is like their new business model to sell like these tests. They sell a few liver tests. I think they just draw the blood and give you the score and some interpretation of it. But you can do it with the components yourself. Yeah.
Right.
It's nothing different about that test.
Excellent. And then some more questions. I'm sure you've seen them regarding treatment. So any benefit from statins?
So statins, there is an ongoing kind of large study of use of statins again for fibrosis, specifically in patients with steatohepatitis. That study hasn't read out yet. My feeling is it's not going to be as strongly positive as semaglutide. We've seen some early data from it, like interim data. However, use of statins where otherwise indicated in these patients is critically important. And so don't let, like, if a patient with fatty liver has an ALT of 50 or 60, but otherwise would benefit from a statin, start the statin. Don't worry about the liver enzymes. Statins are like so well studied in terms of, do they cause liver damage through a drug-induced like injury? And they can cause elevated liver enzymes in about 10 to 15% of patients, but they almost never cause damage. So don't let a pre-existing elevated liver enzyme be a reason not to start the statin. So I think with the statin story, it's more so don't restrict statin use in these patients rather than use statins specifically for the fatty liver.
Great. Thanks for clarifying that. And actually, there was a question which you answered, which I thought might be helpful just to go over. Someone had asked about the use of Tylenol in patients with liver disease. And I just wondered if you could clarify in terms of like the 4 grams versus 2 grams total daily dosage.
Yeah, sure. So that's the use of acetaminophen.
Acetaminophen?
Acetaminophen. If anyone watched the recent Trump,
sorry, yes,
yeah,
yes.
that would
Thank
be.
you for correcting.
So that's me
there.
trying to tell a joke here.
Yeah. Okay. Yep.
Okay. So yes, acetaminophen, Tylenol, very safe in patients with liver disease, even advanced liver disease. The toxicity that occurs from acetaminophen is entirely dose dependent and dependent up. It has to do with sort of the shunting of acetaminophen metabolism to this like toxic pathway. You do not shunt acetaminophen to the toxic pathway until you take a certain amount of it. And patients with liver disease, they still can metabolize Tylenol normally, just maybe a little bit less of a threshold, lower threshold than patients without liver disease. So patients with advanced cirrhosis, we will set a limit of 2 grams per day. And for patients who have well-compensated cirrhosis or no cirrhosis, you can use up to 4 grams a day safely. There's debate about whether 4 grams at a population level is actually still too high, like whether it should be 3 grams. I think in other jurisdictions, they say 3 grams. But, currently here in Canada, it's 4 grams, which is fine.
Great, thanks very much.
And it's actually my preferred therapy, first-line therapy for, pain management, fever management in my sickest patients.
Okay, good. That's good to hear and reassuring. A few more questions around treatment. So I guess just comparing, what about tirzepatide versus semaglutide for fatty liver treatment?
Yeah, I mean, you wouldn't be surprised to learn that there's a study going, obviously, by the manufacturer of that drug for fatty liver. I'm sure it's going to be positive. The benefit of semaglutide is not specific to semaglutide. It's probably a class effect, and it's related to weight loss. So, can I sit here and tell you that there is evidence for tirzepatide? Like there is for semaglutide? No, we don't have phase 3 data. Will we one day? Probably yes. Do I expect it to be similar? Yes. But I think, from the perspective of, what you do for your patients today, I think semaglutide is your best option based on evidence.
Great. And then another question, which I think you had up on your slide, but we didn't have time to go into it. Can you comment on the use of coffee and vitamin E? I've heard some recommendations about these, and if so, how much, and is there some evidence behind them?
So coffee is great for the liver. It has a protective effect. It's not the same effect with tea. It's not the same effect with decaf. It's drip caffeinated coffee. So the thing I tell my patients is if you drink coffee, you can drink a little bit more safely. If you don't drink coffee, you might want to start and do but not the Tim Hortons double or triple that some people order. The cream is not great. In terms of, so the vitamin E is a little bit more of an interesting story. So vitamin E was one of the first studied agents for management of steatohepatitis in a study called the PIVENS trial. It appears to have a protective effect, probably through its antioxidant type, effect, basically, on the mitochondria. But the issue with vitamin E is that, this is where you have to zoom out for these patients, right? If I told you that there's a treatment that improved their liver disease but increased their all-cause mortality risk, you'd tell me that I'm crazy to prescribe it to anyone, because most of these people don't die of liver disease. They die of cancer and heart attacks. And the problem with vitamin E is that there's large studies, population level studies, that show it's associated with high levels of consumption are associated with breast cancer in women, lung cancer in men, and increased risk of myocardial infarction. So I think because of that, it's never really caught on as a treatment for fatty liver specifically. Now, before we had semaglutide, I was prescribing it to patients who didn't have any underlying, cardiac risk factors. Like they were these, lean NAFLD patients without diabetes, without high blood pressure. So there may have been a specific population in the past, but I think in that population now you're going to favor semaglutide over vitamin E. So I think the role of vitamin E is very much diminishing in the treatment of fatty liver.
Great, thanks for clarifying that. I think we've got time for 2 more questions, and I'm actually just going to pull one out of the chat, which I think is helpful. Would be good to answer is, should people with fatty liver have repeat ultrasounds to monitor progression?
So the ultrasound is repeating the ultrasound if they don't have cirrhosis is not recommended and not required. you know, a person can be on the right trajectory, but you still see fat on their ultrasound. And you know, at that point, all you're doing is disappointing the patient, right? You're not, despite the fact actually they're doing the right things and they're improving their own prognosis. An ultrasound in some individuals is so incredibly, it's so easy to detect the fat because of just the sort of morphology of their liver that you might never see it go away, but it doesn't mean anything. In patients with cirrhosis, we do regular ultrasounds, but that's for a different purpose. That's the screen for hepatocellular cancer. And that's ultrasound every 6 to 12 months.
Okay, great. And we'll finish with one last question, which is why are NSAIDs not used in patients with liver disease?
So I would, great question. That I think it's an incorrect statement. So NSAIDs can be used safely in patients with liver disease, just like they can in anyone else. There is a specific population of patients where we worry a little bit about NSAIDs, and those are patients with very advanced liver disease who have significant portal hypertension. So if like your platelet, if the platelet count is less than 100, that kind of might be the signal. The problem with those patients is NSAIDs can predispose or cause hepatorenal syndrome, which is kind of like a downward spiral when it happens for these individuals. But in your walking well patients with fatty liver disease who, you know, find that they need some naproxen or something for whatever ailment they have, there's no reason to restrict it. So like debunking kind of sometimes the I don't even know where it comes from, but debunking the beliefs around Tylenol use in patients with liver disease and NSAID use in patients with liver disease, actually a big part of the counseling we do in the liver clinics.
Great, thanks very much. I think we'll finish there. There's lots of kudos and thanks in the chat for your session as well as for Dan, and also a comment about someone who knew you as a chief resident. I don't know if you saw that from 20 years ago.
Oh my God,
anyway,
I love it.
Yeah.
I'm gonna find
just
that.
going to bring Dan back to also say thank you to Dan as always for bringing us up to speed, especially on the process issues with that we deal with in terms of vaccines and all the rest, and keeping us up to date on the infectious diseases. I hope everybody has a wonderful weekend and see you guys all in a couple of weeks. Take care.